Welcome back to Mastering Medical. This is part 2 of our renal rapid review, and we are inside the glomerulus. Glomerular disease looks impossible until you realize the exam only ever asks 3 things. Is the urine dominated by blood or by protein? Is complement high or low? And what does the biopsy phrase mean? Get those 3 and the whole chapter collapses into a decision tree. We start with the master split, then work through the classic pairs. Let's go. We start with the split. Everything else hangs off. A child develops cola-colored urine, puffy eyes, and high blood pressure after a throat infection. Both nephritic and nephrotic syndrome cause edema. The urine is what separates them. Is it leaking blood or is it leaking protein? Nephritic syndrome is inflammation. The glomerular capillary wall is injured, so red cells escape into the urine. You get red cell casts, cola-colored urine, hypertension, oliguria, and proteinuria that stays under 3.5 grams per day. Nephrotic syndrome is a barrier problem. The podocytes or the filtration barrier fail, so albumin pours out. You get proteinuria above 3.5 grams a day, low serum albumin, edema, high lipids, and oval fat bodies that show a Maltese cross under polarized light. So the moment edema appears, ask one question immediately. Is this urine dominated by blood and casts, or by heavy protein and lipid? That single fork organizes everything that follows. Now the classic nephritic pair, and the one students lose points on because they only memorize half of it. Hematuria shows up after an upper respiratory infection. 2 questions decide it. How many days after, and what is the complement doing? Immunoglobulin A nephropathy, also called Berger disease, produces gross hematuria during or within a day or 2 of the upper respiratory infection. That tight timing has a name, synpharyngitic, and it is your first clue. Immunoglobulin A immune complexes deposit in the mesangium, and complement C3 is normal. Poststreptococcal glomerulonephritis is delayed. Hematuria arrives 1 to 3 weeks after strep pharyngitis or up to 6 weeks after impetigo because it takes that long to form and deposit the immune complexes. Those complexes activate complement, so complement C3 is low and it recovers over 6 to 8 weeks. On biopsy, you get subepithelial humps and a granular, lumpy-bumpy immunofluorescence pattern. Use timing and complement together, not separately. Same week hematuria with normal complement is immunoglobulin A nephropathy. Delayed hematuria with low complement is poststreptococcal disease. Into nephrotic territory. 2 podocyte diseases that look the same on the surface, but split cleanly by age and by steroid response. And the practical question the exam really wants. Do you biopsy this patient or do you just treat? Minimal change disease is the child with nephrotic syndrome, typically age 2 to 8. Light microscopy is normal, immunofluorescence is completely normal, and the only finding is diffuse foot process effacement on electron microscopy. It responds rapidly to steroids. 2 classic triggers worth remembering: NSAIDs and Hodgkin lymphoma. Focal segmental glomerulosclerosis is more often the adult, and it carries associations: HIV, intravenous heroin use, severe obesity, sickle cell disease, and higher risk in patients of African ancestry. Light microscopy shows sclerosis in part of some glomeruli, which is exactly what focal and segmental mean, and steroid response is partial or absent. Now the practical rule. In a child under 10, do not biopsy first. Minimal change is overwhelmingly likely, so treat empirically with prednisone, and biopsy only if they are steroid resistant after about 8 weeks, or have atypical features like hematuria, hypertension, or low complement. In adults, biopsy is mandatory. For focal segmental glomerulosclerosis, add an ACE inhibitor for proteinuria, a statin for the hyperlipidemia, and consider anticoagulation if serum albumin drops below 2 grams per deciliter. Now the 2 diseases that remodel the capillary wall itself. This pair is pure pattern recognition, and it is decided by 2 words on the biopsy report plus 1 lab value: spike and dome or tram-track. And what is complement doing? Membranous nephropathy is pure nephrotic syndrome in an adult. Immune deposits sit on the subepithelial side of the basement membrane, and the membrane grows spikes between them, which is where spike and dome on the silver stain comes from. Immunofluorescence shows granular immunoglobulin G and C3, and serum complement is normal. In primary disease, the phospholipase A2 receptor antibody is positive in roughly 70%. Always hunt for a secondary cause. Hepatitis B, lupus, syphilis, a solid tumor adenocarcinoma, NSAIDs, gold, or penicillamine. Membranoproliferative glomerulonephritis is the mixed one, nephritic and nephrotic at the same time. Deposits are subendothelial and mesangial. The mesangium proliferates and burrows into the capillary wall, and the silver stain shows a tram-track double contour. Complement is low, and that is the fastest discriminator. Both C3 and C4 low in type 1. C3 alone low in type 2, which is dense deposit disease. Type 1 is classically hepatitis C with cryoglobulinemia, and type 2 involves the C3 nephritic factor. So read the light microscopy phrase and the complement level together, and it falls out. One management point for membranous. The risk of venous thromboembolism is genuinely high, so anticoagulate if albumin drops under 2.5 grams per deciliter. Last pair, and it is the one that ties this whole video together. Lupus nephritis is classified by number, and every number maps onto a physiology you have already learned in this video. Class 3 and 4, Class 5, or Class 6. Nephritic, nephrotic, or scarred. Class 3 is focal proliferative lupus nephritis, involving less than half the glomeruli. Class 4 is diffuse proliferative, involving half or more, and it is both the most common and the most aggressive. Both behave nephritic. Red cell casts, subnephrotic proteinuria, hypertension, falling filtration. Complement C3 and C4 are low, anti-double-stranded DNA is high, and immunofluorescence shows the full house pattern, meaning immunoglobulin G, immunoglobulin M, immunoglobulin A, C3, and C1q all light up. These get induction with high-dose corticosteroids plus mycophenolate or cyclophosphamide, then maintenance with mycophenolate or azathioprine. Class 5 is membranous lupus nephritis, and it behaves exactly like the primary membranous disease we just covered. Heavy proteinuria above 3.5 grams, low albumin, edema, subepithelial deposits, and complement that is normal more often than not. Class 6 is advanced sclerosing disease. More than 90% globally sclerotic. There is no inflammation left to suppress, so management shifts entirely to slowing progression and preparing for renal replacement. Translate the class number into physiology first, and the management follows on its own. Let's lock it in. Red cell casts and hypertension is nephritic, while more than 3.5 grams of protein with lipiduria is nephrotic. Hematuria during the infection with normal complement is immunoglobulin A nephropathy, while hematuria 1 to 3 weeks later with low complement is poststreptococcal. And a child with normal light microscopy who responds to steroids is minimal change, while an adult with segmental sclerosis and steroid resistance is focal segmental glomerulosclerosis. Spike and dome with normal complement is membranous, while tram-track with low complement is membranoproliferative. In lupus, classes 3 and 4 are nephritic, class 5 is nephrotic, and class 6 is scarred and irreversible. And the habit that makes all of this fast: sediment first, then complement, then the biopsy phrase, in that order every single time. That is part 2. Part 3 moves to the kidney diseases you inherit and the ones that arrive from the rest of the body: polycystic disease, Alport, amyloid, the pulmonary renal syndromes, and renovascular hypertension. See you there.